I am Shareefah Shereef, the head of the Cath Lab Technicians at Al Dabous Cardiac Center in Kuwait. It's truly an honor to be here with you today, presenting this important consensus paper, Radiation Safety Beyond the Standards, the Gulf Region Consensus for Cath Lab Practice. First, I want to take a moment to thank GIS for establishing the first board in our region dedicated to cardiovascular professionals. I'm truly proud to be a board member, and this leadership opportunity has allowed me to represent my colleagues and has given us a real platform to connect, share experiences, and openly discuss the challenges we face in our cath labs. During these discussions, we discovered that radiation safety policies vary widely from one center to another, and some practices are still not fully aligned with international guidelines. And that's what inspired us to create the first regional evidence-based consensus on radiation safety. But this is only the beginning, the first step toward a stronger radiation safety culture in our region. We will continue to monitor the changes and impact of this consensus, follow up with regular meetings, and update you on our progress. Before I move forward, a special acknowledgement goes to Dr. Fawaz Lamtairi, the President of GIS, for his trust, support, and vision, and for giving me the opportunity to moderate and lead this first regional consensus on radiation safety. It has been an absolute honor and a truly collaborative journey. And now, let's move on to the rationale behind this consensus. Every day in the cath lab, we stand between precision and protection. We navigate wires and catheters through the heart, all while standing beneath invisible rays that we can't see, we can't feel, but can leave lasting harm. For many of us, radiation safety has always been about compliance, ALARA, aprons, and dosimeters. But what if safety is more than just policy? What if it's a culture, one that values the well-being of every operator, healthcare provider, and patient? My passion to radiation safety began years ago, watching how often we celebrate procedural success, yet forget the quiet risks we are exposed to every single day. Over time, that passion became a mission to move radiation safety beyond the standards. And this is what led to the Gulf Consensus Project, a collaboration that brought together experts from across the Gulf. Together, we reviewed what's already done well, and more importantly, what's still missing. The reason this consensus is so crucial is simple. There are still gaps in radiation safety practices across Gulf cath labs. While most centers follow the basic protocols, some critical measures remain inconsistently applied, even though international bodies like ICRP, NCRP, SKY, and ESC have already provided clear guidelines. To address these gaps, we set clear objectives to identify underused radiation safety measures, adapt international best practices to the Gulf region needs, and establish unified regional recommendations for cath lab radiation safety. Now moving to the methodology, the Gulf Consensus on Radiation Safety in Cath Labs was developed through a collaborative panel of experts from Kuwait, Saudi Arabia, United Arab Emirates, Oman, and Bahrain. Each panelist was selected based on their direct involvement in cath lab practice with proven experience in radiation protection and occupational safety. The process followed a structured approach. First, the selection of panelists, chosen for their professional expertise and commitment to advancing safer practice. Second, the collection of written recommendations. Third, we assigned a level of evidence to support each recommendation using Oxford Center for Evidence-Based Medicine classifications. Fourth, an extensive review of those recommendations was conducted against international references, including ICRP, NCRP, SCI, ESC, and IAEA. Fifth, all statements were refined and harmonized through discussion, ensuring clarity, practicality, and regional applicability. Finally, the entire process was moderated by myself, ensuring balanced contributions and final agreement on each statement. This table shows Oxford Center for Evidence-Based Medicine classifications that we used to support all the recommendations in this consensus. It has 5 levels of evidence. Level 1 is the strongest. It could be, for example, systematic review or randomized trial. Level 5 represents expert opinion. Before we move on, I'd like to briefly introduce the main international scientific organizations that set the foundation of radiation protection and safety across the world. First, we have ICRP, the International Commission on Radiological Protection. It is an independent scientific body established in 1928. All its recommendations set the core foundation of all radiation safety policies worldwide and are adopted by major international organizations, including NCRP, IAEA, and SCI. Then we have IAEA, the International Atomic Energy Agency, and NCRP, the National Council on Radiation Protection and Measurements. Lastly, we have SCI and ESC. They are well known to everyone in cardiology. All the recommendations in this consensus are based on and referenced from these most recognized international organizations. And now, let's dive into the consensus itself, starting with statement number 1, the dual dosimetry. Cath lab staff should wear 2 dosimeters, one under the lead apron at chest or waist level, and the second outside the apron at collar level, to measure the shielded and unshielded exposure. Because in most cases, staff's trunk is shielded by apron, while the head, neck, eyes, and extremities remain unshielded. Therefore, guidelines recommend wearing a second dosimeter outside the apron at collar level to monitor radiation exposure to unshielded organs. In case of only 1 dosimeter is available in your cath lab, guidelines recommend wearing it under the lead apron at chest level facing the radiation source. Next, we have statement number 2. Pregnant cath lab staff must be provided with protective measures, including maternity lead apron, fetal dosimetry, and modified duties. The maternity lead apron should be a maternity tailored design with at least 0.5 millimeter lead equivalency. There are several international publications that support this statement, including studies published in JACC, American College of Cardiology, and Circulation. In addition to that, pregnant staff should utilize a portable shield with at least 1 millimeter lead thickness and adapt any advanced radiation safety technology available in the cath lab. The fetal dose should not exceed 1 millisievert over the entire pregnancy, and for female patients of childbearing age, a pregnancy test must be done before the procedure. Next, statement number 3. All cath lab staff should undergo a radiation safety course every 2 years, with certification renewal as a requirement for continued access. Evidence from IAEA shows that training reduces radiation dose in interventional cardiology. We suggested a 2 years interval aligning with other hospital training cycle, a reasonable period to keep skills fresh and prevent knowledge from fading. Next, statement number 4, in complex PCI, including multivessel PCI, left main PCI, and CTO, cumulative air kerma thresholds should be used to guide procedural continuation or termination in order to minimize the risk of radiation hazards. The suggested dose threshold for single vessel PCI is 2 gray, for multi-vessel PCI or left main is 3 to 5 gray, and for CTO it's 5 to 7 gray. All international guidelines recommend using cumulative air kerma of 5 gray as a cutoff value to decide whether to proceed or to stop the procedure. But it shouldn't be a rigid stop rule because there are other factors that may influence the radiation dose. For example, patient body habits or machine geometry. SKY recommends using live intra-procedural notification to alert the operator when radiation dose reaches 3 gray and to notify repeatedly for every extra 1 gray. Then we have statement number 5. Patients with either peak skin dose of 3 gray or more or cumulative air kerma of 5 gray or more must have radiation dose documented, be counseled, and receive structured dermatology follow-up, first within 10 to 14 days, then 2 to 4 weeks, and again at 6 months, to detect delayed skin injury. International guidelines advise cath labs to monitor and document radiation dose for every procedure, and it should be reported in patient procedural report. SKY recommends that when radiation dose exceeds 5 gray or fluoro time exceeds 60 minutes, documentation and patient follow-up are mandatory. Lastly, we have statement number 6. Institutions must establish policies for dose monitoring and incident reporting. Any exceedance of dose limits must trigger investigation and corrective action. All international guidelines advise cath labs to define the trigger level where investigation, incident reporting, and corrective action are mandatory. The corrective action should be technical, educational, and systematic. In summary, adapt these consensus recommendations as minimum standards, integrate them into the national accreditation frameworks, emphasize continuous training, monitoring, and reporting, promote research and local data collection to refine protocols. Thank you.